Week number 2, lecture number 6. Hello friends. In previous lecture we discussed about communication between healthcare professionals. Now we are talking about communication competence in health professionals. And again, like I said in last lecture, it is applicable to each one of us. We should be communication wise competent so that we can convey what we want to convey to other people. How do we convey it well? Some of you must have heard the name of, particularly who reads books and who is interested in literature, must have heard the name of one Indian born English author, Rudyard Kipling. Rudyard Kipling, he had written lots of novels and basically the background has been India. I read one of his novels known as Kim, K-I-M, Kim. He wrote once, I keep 6 honest serving men. I keep 6 honest serving men. They taught me all what I know. They taught me all what I know. And their names are what and why, where, how, where, who. All these things, whenever you ask these questions, what, when, where, how, who, and whatever information you get, you generally get a detailed story about the subject what you want. In fact, this particular technique is being used by a police department whenever something happens, something unusual happens, and when they start with the investigation, they go to a particular case, particular place where burglary or murder or anything has taken place, and they ask these questions to themselves and slowly find out the whole mystery as such. Let's consider this in our own case. Basically, you are going through the course of basic certificate in palliative care. Now, you want little information about this course. Ask the question, what? When I say what means, immediately you will say we are talking about this course given by Swayam Portal. It's on the internet and the name is Basic Certificate in Palliative Care. Why? Why do you do this course? We are interested because palliative care is something which should be known by everybody, even by family member. It is open to all who wants to know, who wants to care themselves, who wants to care their elderly people, some basic knowledge. Where is it taking place? It's under Swayam Portal, open it. You can also register yourself. How? You give out the whole process as such, and you say if you really require a basic certificate, then you have to pay certain fees, very minimal amount. There are 12 weeks starting January 2024. So, all this information comes where, how, who is taking. So, it is being done by NAPCIM, National Association for Palliative Care of Ayush and Integrative Medicine, and it is being held by IIT Kanpur. So, these few words, what, when, where, how, why, give you the details of this, and this is required, and this is called communication competency if you make use of this knowledge. What is communication competency? The usefulness of communication in health profession, otherwise also in our life. This presentation pertains, but most of the things, most of the points are applicable to our life also, personal life as well as work life. How to increase communication competency. Part 1, communication competency. Communication competency encompasses language first, because after all communication needs to be passed. If it is a verbal communication, two types, verbal and non-verbal. If it is a verbal, then it needs some language. Grammatical knowledge of syntax means words formation. You got to collect information and make a sort of paper. Morphology, the structure of the event. Biological study of an organism, like we can say anatomy in doctor's profession. Phonology, that is about the speech and sound. If it is the non-verbal, that means you are giving it away through words power, oral power. So you must understand what is the phonology, how do you speak, and the things like that. So this is what requires in communication competence, and as well as social knowledge. When you are acting in a society, you require social knowledge. If you are working in a work life, professional knowledge, hospital, medical knowledge, and when to use utterances appropriately, your own experiences and utterances, where it is required and where it cannot be uttered. The understanding of communicative competence has been influenced by the field of pragmatic and the philosophy of language, including work on speech acts. So, in communication competency, the most important thing is the language. You must understand one language. In India, I just say Hindi, English and your regional language. These three languages you must master it. A written part as well as oral part. You may be talking, but sometimes your talk doesn't give any sense, doesn't give any meaning to others, to the listeners. So your proficiency in language is very important to have a good communication competency. Why it is required? We believe in patient-centered care. In any case, the philosophy of medical care is what? It has to be patient-centered, unlike what is happening nowadays in commercial hospitals. The aim has been shifted from the patient towards earning money. No, it is not that. In a proper medical philosophy, the patient's safety comes first and foremost. It has been told again and again by Dr. Geeta Joshi in her lectures. There is something known as Kalamazoo consensus statement. Check in the Google, find out what it is, and then you will understand what is patient-centered health policy. Errors decrease by improved training. If your communication is proper, if you are a good communicator, effective communication skills are there, then normally those errors which we generally deliberated in the earlier lectures will be eradicated, it will be limited. Errors may take place, but then you will be able to handle it properly. Of course, to err is human, errors will take place, no doubt, but when you practice it, errors slowly and slowly will be diminished. Health disparities, unequal treatment, that is not our goal, and therefore the communication competency is required. Why is important? Facilitation of information exchange, and information needs to be exchanged firstly from patient to the doctor, and that becomes the basis, foundation of case history. Thereafter, from doctor to the patient, whatever prescription he writes, this is the medication and the complete care plan, this is how plan of action is there. So, this way it will take place, it will keep on taking place till the time a patient gets recovered fully. This exchange of information will keep on taking place between patient, doctor, nurses, patient's relatives, round and round. Healing relationship, and that is where empathy that yes we spoke about in our previous week number 1. We should be empathetic in our communication, not only in communication, in fact that should be a part of our quality. As a human being, we must go for humanistic approach. We cannot become a terrorist, or we cannot become a sort of money monger. We want to loot all the money from the patients. No, our approach is to heal the patient, cure the patient, heal the patient as early as possible. Mutual development, you establish relations and that relation goes on forever. Black box in family medicines, family practice and patient visits are complex with competing demands and opportunities to address a wide range of problems of individuals and families over time and various stages of illness. Multi-method research in practice settings can identify ways to enhance the competing opportunities of family practice to improve the health of that practice. Certain distinction between interaction and relationship. Interaction means what? Like I am interacting with you. There is a relationship. You can call me guru and you are the shishya, or I am a teacher and you are the students, or it can be anything. But it had not been well formally established. Now presently only interaction of certain information about this course, basic certificate in palliative care, is taking place. Relationship, yes, when interaction becomes longer and longer over a period of time, some bond is, mutual bonds are being created or certain feelings, that is relationship. Communication skills do not constitute the doctor-patient relationship. It can, it is required, it is expected, but it is not a necessary part of doctor-patient relationship. Doctor-patient relationship, if it remains with healthy interaction, with the sole aim of patient's safety, then communication has done its job. Primary aim has been served. There are 4 approaches. First is the communication skills. We must know about it, because most of the time we do not know what is the communication. For us, communication means just bachit, gupchup. No, it is not that. Communication is always intended for a desired effect. Desired effect means you want someone to take a particular action on a particular message. That is called communication. It is not just wasting time and talking it out. Conflict management, this is very important, because we are social animals. We live in society, but sometimes we act as animals. And what animals do? Senselessly they fight amongst themselves. We human beings do the same thing on certain pretext. So in such a situation we require conflict management, and conflict management cannot take place without gentle and proper communication. That is where your communication skills will come into account. Anger is not required. What is required is logic. Apply logic, talk to the people, and situation will be sorted out. This is what is happening. Sometimes conflicts do arise. In health administration also it arises even amongst the staff itself. Forget about the patient and the staff. So what do? That is where your communication competency will come into effect. Teamwork. What is team? Together everyone achieves more. Cooperation, we remain united, we learn from each other. And when everybody gets together, tremendous power gets generated. And through that power, you can do Herculean works also. Himalayan tasks can be completed by that. Teaching others, yes, we have to teach others. Like I come here basically not exactly to teach you, but to share my experiences about communication. So these are the approaches which can be adopted. Communication skill can be increased, conflict management, teamwork, and teaching others. Now this is important. When you talk about communication competence, it has got certain characteristics. Firstly, it's a property, individual property. And when I say individual property, it basically depends upon the quality of an individual. What is my qualities are inborn. Qualities and skills, like I told you in my lectures, quality is inborn. It is something with me when I was born. And skill is something what I need to acquire now, and it can be learned and practiced, and I may take the help of some training professionals. Individuals are different. Many men, many minds. In Sanskrit we say, tunde tunde mati hi bhinna. Peoples are different everywhere. So that is a situation, each individual is different and their communication competence is different. This we must understand. We must just, we cannot take it that I know English, so everybody knows English. I am better in my communication skills, so everybody is better in communication skills. No. It is the property of individual that we must understand. If somebody is not good, then we must try and train. If somebody is good, very nice, we must appreciate and learn something from him. Assessment of individual skills, abilities and behavior needs to be done, and as per that a person can be given additional training. It's a property of interaction. If there is no interaction, then there is no communication. Whenever interaction is required, then the communication gets established. If patient remains at home and doctors are sitting there in their hospitals, there is no interaction, there is no communication between them at all. Communication starts when a patient comes to the hospital and reports to the doctor, yes, this is happening. And that is the time communication starts, and we talk about communication competence that point onwards. Property of interaction. No interaction, no communication. Interaction is present, communication is present. Interactional or dyadic qualities, including adaptation, control, collaborations. This again, it needs different types of language skills, behavioral skills to understand this and apply it. Relational viewpoint of assessment. Focus is longitudinal, same person, because you talk to the same patient about the same disease whenever you meet him. Focus is cumulative. So whenever you keep talking to the patient over a period of time, when he is in your hospital, when he is inpatient, during your visits, you speak to him, and over a period of time, the lot of information is being collected about the patient, social liabilities, his health and other conditions, including the outcome of the medication what we have suggested. Focus is on participants' sense of connection and satisfaction. Who are the participants? In our case, it is basically the doctor, the nurses, the patient and the relative. There are 4 participants. If you want to satisfy them, then this communication needs to be better, and that is how who will be the happiest one? If there is a good communication and good outcome, that means the problem, the disease has been removed, it has been treated well, the patient, and thereafter it is the doctor. He has done his job, he is very happy, yes, one of my patients got fully well and he has just gone back. It's a professional satisfaction what he gets out of his treatment, well done treatment. May be observed by non-participants. Who are the non-participants here? Family members, the relatives and everybody, they knows the output, what has happened, how it has gone. If patient died in the hospital, they know, okay, no, something bad has happened. If patient goes out happy, smiling, strong as he was earlier, then again they get positive points, positive look for the hospitals. Methods, didactic sessions designed to teach something to the people about lectures and demonstration, that is what I am doing. Standardized patients, role play, videotape review, co-counseling sessions, observed counseling sessions. These are the various teaching methods to increase communication competence. It can be done at a systematic level, can be done in the hospital itself, can be taught in colleges, in management schools. Layered level means communication has got 3 layers: content, and whatever, whenever you are giving out content, it should be organized logically. It should be organized as per the topics. Topics management, like you must have seen when you go through this particular course, basic certificate in palliative care, you will see all our presentation have been, the contents have been given out in a various logical ways. If the presentation is little long, we are divided into part 1, part 2, part 3. Subject, sub-subject, and that is how we go about it. Content level, so that it is easy to express and easy to understand. Process, second is the process. Pacing, facilitation, congruence, matching, effective displays, that is a process. You express it when the data, when the lecture, when the subject matter is being transferred from speaker to the receivers. And then comes something invisible, that is mindfulness, and that is where we said active listening. If your mind is open, if you live in present, you understand, you must know that past is history, past is a history and future is a mystery. So forget about both these things. History is gone, we can't do anything about it. Mystery, what is going to come tomorrow, we do not know anything. What is happening is the present. So let's enjoy the present, and when you remain in present, then you become mindful. So these 3 things, content level, process and meta process, these are the 3 layered levels of communication competence. Ways of knowing: traditional medical education, that is being done in colleges, nursing colleges, medical colleges, pharma colleges. Practicum training, it is being given there only, residential training. Procedural and separate knowing, that has to be done by individual person. And connected knowing, personal experiences, collaboration, use of patient's language, understanding of patient's perspective, acknowledge effects of caring on provider. Connected knowing, and this is where our course comes into it. Whatever is connected with your profession and with your life, you must try and learn about it. Connected knowing. In the end, processing, perceptual and conceptual skills must be integrated into the curriculum, because where they are taught separately, conflicts emerge and the maximum of compliance and efficiency in patient care is not achieved. This point, I will just give you few words. Sorry to say that this particular subject of communication was never integrated with our medical curriculum so far. They did not believe that there is something known as communication between patient and doctors, and it is for the well-being, for the safety of patient, it is necessary that we teach this subject of communication in various medical colleges. Luckily, the thing has started now since last 2-3 years. They have started with a foundation course of 1 month, and some of the communication lessons, empathy lessons, ethics, that is being taught in the first month itself of MBBS and nursing courses. So, certain steps have been taken. This particular subject has been included in the curriculum, but it is not enough. It is just not enough. In Western countries, in developed countries, communication being given lots of importance. In fact, communication is the basis of all medical care, because you cannot start medical care without proper communication. If communication goes wrong, medical care can go wrong and you may get involved into medical legal problems. Thank you. Thank you, dear friends.